So let's take a look. There is something called Perineoblastic Syndrome. The idea of Perineoblastic Syndrome that the tumor cells themselves start secreting a substance that normally should not be secreted from that area. These substances can be antibodies, they can be hormones, they can be enzymes, okay? And according to what they are secreting, the patient will have symptoms. For example, here they mention musculoskeletal and cutaneous Baronioblastic syndrome, endocrinological Baronioblastic syndrome, hematological Baronioblastic syndrome, and neuromuscular Baronioblastic syndrome. Again, the idea of Perineoblastic syndrome is that the tumor is making substances that should not be normally made there. For example, antibodies or hormones or even enzymes, or it can be even some totally different material. So let's take a look. Starting with musculoskeletal and cutaneous Baronioblastic syndrome. Dermatomyositis. So dermatomyositis is a condition in which you have antibody against your against anti-Jo antibody, we call it GO, anti-Jo antibody. And these, when you have these antibodies, you are going to have basically inflammation of your skin and your muscles. Inflammation of the skin will lead to, starting with the muscle, inflammation of the muscle will lead to proximal muscle weakness. Keep in mind that the symptoms of a proximal muscle weakness include inability to comb the hair. The patient is unable to comb his hair. Also, the person is unable to reach out for an object that is locating over a closet or over the refrigerator, for example. Also, they have cutaneous symptoms because of the dermatomyositis, is the dermatoportion, like Guttrin babules. So Guttrin babules. We will see this pathology again in MSK, but for now you just need to get a general idea about it. So you can see this Guttrin babules on their fingers, and it likes to affect also this knuckles region, as you can see. Okay. So the tumors and the heliotrope rash. The heliotrope rash is a rash that goes around the eyes, as you can see here. So yeah, the heliotrope rash is a rash that is going around the eyes. Good. So this is the heliotrope rash. So the next thing is, what causes it? Well, here they write adenocarcinoma. Okay, adenocarcinomas, especially ovarian adenocarcinoma. But to be fair, it can be literally any visceral cancer. Pancreatic adenocarcinoma, yes, that can cause it. Well, what about lung adenocarcinoma? That can do it as well. Any form of adenocarcinoma can lead to it. Esophageal adenocarcinoma, yep, it can do that. Okay, the next one is Acanthosis negligence. So in case of Acanthosis negligence, you need to differentiate between two types of it. So taking a look about Acanthosis negligence. Yes, it can be due to a cancer, but not always. What other condition can lead to Acanthosis negligence, guys? Which is this thing. Diabetes mellitus, correct. So it looks something like this. Yeah, I know, it's kind of bad. So yeah, polycystic ovarian syndrome as well, correct? So here is the thing, and actually in polycystic ovarian syndrome, the cause of the Acanthosis negligence is the insulin resistance. So it's due to insulin resistance. You are like, okay, so since you are telling me it can be due to tumors and also it can be due to diabetes, how can I differentiate between the two? You know? The way to differentiate if this Acanthosis negligence is due to cancer or due to diabetes mellitus is by time. If it happened really quick, is it diabetes mellitus or cancer? Tell me, please. It's cancer. If it happened really quick, it's cancer. But if it happens like after a lot of time, it took a lot of time to happen until the build-up, until all of this dysfunctional insulin buildup, then it is diabetes mellitus. Okay, so here you can see it hyperpigmented velvety plaques in the axilla and the neck, as you saw in the picture here. Okay, so the next thing they write here is it has a relationship with gastric adenocarcinoma and other visceral malignancy. Okay, the next one is something called the lesser relate sign, which is a multiple sporadic keratosis, seborrheic keratosis. So let's take a look at that. Seborrheic keratosis is not seborrheic dermatitis. These are different. So when you take a look at the seborrheic keratosis, it has this stuck-on appearance. Stuck-on appearance. When you take a look at this, it looks like you wanna just take it off. You know, it looks foreign to the skin basically, and it looks stuck on. So they call it a stuck-on appearance. If you have one, it's not a big of a deal, you know. But if within few days you had hundreds of them all over your back, something like this, that occurred in the matter of a week, that's cancer, okay? That's gastric cancer, and this is a Baronioblastic syndrome, okay? Not sure what people are writing. Okay, so yeah, this is a relate sign, which is due to gastric cancer. Okay, so GI adenocarcinoma, other visceral malignancy can lead to it as well. Now, the hypertrophic osteoarthropathy. So hypertrophic osteoarthropathy, these patients will be suffering from clubbing of the fingers, and most likely it's due to lung cancer. And they write it's an abnormal proliferation of skin and bone at distal extremities. So the patient will have a clubbing, arthralgia, joint effusion, periostosis of tubular bone. Let's take a look at it. The size of your fingers will be humongous. See, it's really big. It is the same type of thing that happened in COPD, but basically the mechanism here is different. Yeah, but this is also due to lung problem, lung cancer. Okay, so the next one, it goes something like this. Endocrinological Baronioblastic Syndrome. Again, Baronioblastic Syndrome is a syndrome that occurs due to the tumors secreting foreign particles to the body, leading to different symptoms not related initially to the tumors. So an endocrinological one, it can be what? Hypercalcemia. Why? Some cancers like squamous cell carcinoma of the lung, head, neck, bladder, renal, breast, ovaries, doesn't matter. Squamous cell carcinoma, if it affects literally any organ, it will give you parathyroid hormone related peptide. Also, some ovarian cancer can lead to it. So the parathyroid hormone related peptide is not a real parathyroid hormone, which means if they give you an arrow question and ask you, in case of this hypercalcemia due to PTH related peptide, what is going to happen to the level of PTH? What will happen to the level of PTH in hypercalcemia secondary to PTH related peptide? It will be really low, okay? Because the hypercalcemia lead to feedback mechanism which inhibit the PTH. You are like, but it's written here PTH related peptide is high. Yeah, it's a related peptide. It acts on the same receptor, but it's not the same hormone, it's different. Okay, the next one. A patient with lymphomas, remember that lymphomas and the granuloma contain 1-alpha hydroxylase. This 1-alpha hydroxylase leads to hydroxylation of the 25 vitamin D3 and makes it the active form. The 125 hydroxyvitamin D, also called calcitriol, which lead to hypercalcemia and hyperphosphatemia. The next one is a small cell lung cancer, which is a neuroendocrinological form of cancer, and it can lead to Cushing's syndrome by increasing the ACTH. Also, if it has a lot of ADH, it can lead to hypernatremia. Okay. So the next one is the hematological dysfunctions. So if the patient is suffering from an ridiculously increased amount of erythropoietin, because of what? Well, these can lead to it. So they mention here pheochromocytoma, renal cell carcinoma, hepatocellular carcinoma, and hemoangioblastoma and leiomyoma. Actually, these are almost all of them are related to VHL, which is the von Hippel-Lindau. And this is a tumor suppressor gene or tumor oncogene, guys. VHL. Is VHL a tumor suppressor gene or a tumor oncogene? It's a tumor suppressor gene. Excellent. So is it a gain of function mutation or loss of function mutation? Loss of function mutation. So since it's a loss of function mutation, is it a loss of function of mutation of one allele or two alleles? Yes, two alleles, correct. Good. Okay, the next one is a pure red cell aplasia, in which the patient has a humongous reduction of his RBCs with low reticulocyte count, but all of his white blood cells and his thrombocyte are normal. This can be happening due to thymoma, anemia with low reticulocyte count. Good syndrome is not that good. It can lead to agammaglobulinemia-like symptoms, which remind you of Proton's agammaglobulinemia. The only difference that good syndrome is due to a tumor, while agammaglobulinemia is not due to a tumor. And on the exam, the way they give it to you, they give you Proton's agammaglobulinemia-like symptoms, and they give you a patient with a thymic mass, so he can have like a superior vena cava syndrome. And that can lead you to think about good syndrome. The next one is a Trusay syndrome. It's not the same as a Trusay sign. So the Trusay syndrome is something called migratory superficial thrombophlebitis, and it's highly associated with adenocarcinoma of the pancreas. So let's take a look at it. So these patients are suffering from an inflammation of their superficial vein of their legs. And when they have that, thrombophlebitis, come on. So in pancreatic cancer, Trusay, okay, no, syndrome we want. So we want the syndrome, not the sign. Keep that in mind. Yeah, you can see this superficial migratory thrombophlebitis, inflammation of the vein, and it's really painful for the patient. Yep. It's secondary to hypercoagulable state created by the pancreatic cancer. The next one is a non-bacterial thrombotic Marinetric endocarditis. What other disease led to a sterile endocarditis? A sterile endocarditis. Lupus. Excellent. Lupus led to that. So it's a deposition of a platelet thrombi on the heart valves. So the patient can have adenocarcinomas, especially pancreatic adenocarcinomas leading to this one. Okay. So the last thing is neuromuscular disorder. So the neuromuscular disorder goes something like this. We have the anti-NAMDA receptor encephalitis. It happens secondary to ovarian teratomas, and this patient will have psychiatric disturbances, memory deficit, seizures, dyskinesia, autonomic instability, and language dysfunction. Maybe you heard about this lady who got this tumor and started to speak foreign language. You're like, what? Yeah, it's this one. Or in the future, I'll be telling you about a guy who went into a coma and woke up and started speaking Chinese when he did not know Chinese. And the way that happens, that our brain is recording every single moment in our life. Since the day you were born until you die, you have enough place in your brain to record all of that. It's just hidden. But if you dig deep inside, you can find it. And yeah, that's the job of a psychiatrist, to find these ideas sometimes, or actually sometimes it's better to keep them hidden. So anyway, that's deep. Okay, the next one is Obscurus, Myoclonus, Ataxia syndrome, which is dancing eye, dancing feet. Remember about this neuroblastoma? Which additional Baronioblastic syndrome patient with neuroblastoma had? I told you about it today. Neuroblastoma patient can have another Baronioblastic syndrome on their face. What was it? The raccoon eyes, exactly, the raccoon eyes. Yep. Small cell carcinomas of the adult also can lead to Obscurus myoclonus. So their eyes are dancing, their feet are dancing, they are just in ataxic basically. And yeah, I hope I can find like a short video about it, because it's actually like, if you see it once, you cannot forget it. Okay, let's take a look.
Come get the cups. Come on.
Notice, she's ataxic, she is unstable, she cannot bear her feet on the ground. Yeah? So that's the ataxia. Look, she's keeping falling backward because of the ataxia.
Here.
It's hard to focus in her eyes, but her visual orientation will be also really bad. And that means that this little girl is suffering from basically neuroblastoma. Okay. So the next one is Baronioblastic syndrome. Baronioblastic cerebellar degeneration. So you must know that you have Purkinje cells inside of your cerebellum. To be more specific, they are located in the vermis of the cerebellum, which is the structure that is located between the two hemispheres of the cerebellum. So if you have antibody against antigens in the Purkinje cells, that will lead to their destruction. So you're like, okay, what is the big of a deal? Well, if you destroy that, you will have a really bad ataxia, okay? And other ones, small cell lung cancer, like the anti-WHO. So yeah, the anti-WHO can lead to Baronioblastic cerebellar degeneration in case of small cell lung cancer. Gynecological and breast tumor, the anti-U. And Hodgkin lymphoma, it will be the anti-TR, okay? So I remember somebody said Dr. Hodgkins with Dr. Hodgkins, yeah? And the next one is Perineoblastic encephalomyelitis, which is an inflammation of your brain and spinal cord secondary to antibodies against the WHO, again, anti-WHO antigen in the neurons, which can be from small cell lung cancer. So if a patient has an inflammation of his brain and inside of and his spinal cord, he's going to have ataxia and motor and sensory weakness as well. Now the most important two Baronioblastic syndrome. The first one is the Lambert-Eaton myasthenic syndrome, and the second one is myasthenia gravis. If we speak about the neuromuscular junction, you have the synapse here, and you have the postsynaptic cleft here. And you have here a calcium channel, okay? Opening of the calcium channel lead to depolarization of the presynaptic cleft, which lead to release of vesicles to the postsynaptic cleft, which lead to the formation of the action potential. In case of Lambert-Eaton syndrome, you have antibody against these calcium channels. So they write antibody against the presynaptic calcium channels at the neuromuscular junction. That will be in case of small cell lung cancer. If that is true, what is going to happen to your muscle power? It's going to go down, yeah? But what is important? If you keep trying to move your muscle, more and more calcium will start trying to enter. So that will lead to basically competitive kicking away of the antibody. So more calcium, less antibody to fight over. So what I'm trying to tell you that in Lambert-Eaton myasthenia gravis, the more you use your muscle, the less weakness you have. This is in contrast of myasthenia gravis. In myasthenia gravis, the antibody are against the receptor, which is the acetylcholine receptor in this area at the postsynaptic cleft. So if at the postsynaptic cleft the antibody are against it, you will not be able to stimulate these receptors. And it's most likely due to a thymoma. So they like to show you this picture actually. A CT scan. And they show you this mass. You must know that the thymus is located at the anterior mediastinum, and thus the T here represents the thymus. So when you see this, you are like, okay, he has thymoma, muscular weakness, is myasthenia gravis. Be careful, because they can show you, they can show you something like this. They can show you a small cell lung cancer. In the future, I'm going to tell you something about the small cell lung cancer. Small cell lung cancer like to affect the center of the lung, not the periphery, the center of the lung. Notice, it has an S, center. So it likes to affect the center of the lung, but it does not affect the anterior mediastinum. So this is a way to differentiate between myasthenia gravis and Lambert-Eaton syndrome. So again, this is a thymoma, so this is myasthenia gravis. And this picture is having like this mass, not in the anterior mediastinum. So this is a small cell lung cancer, which is associated with Lambert-Eaton. So muscular symptoms plus lung cancer, Lambert-Eaton. Muscular symptoms plus a thymic mass. This is myasthenia gravis. Okay, and that's it for this one topic. But I want to tell you one more thing. So we are done with the pathology. Guys, today's topic has plenty of memorization. Please do print this page. And for the other pages, please download Anki. For those who do not have Anki and do not believe in it, you should start doing Anki as early as possible. If you do not have access to Anki, contact me and I will give you the access to Anki. But you need to start doing Anki because this is the only way you can memorize these. Okay, so far we are done with pathology and cardiology. Pretty soon we will be done with renal. It's not that long. And we'll be starting immunology and endocrinology. Okay, so let's just take a quick look here. Okay, no, this needs to be tomorrow. Okay, so anyway guys, that's it for today and we will continue tomorrow at the same time. See you tomorrow guys.